Her research question, she also researched an ambulatory team for community care with severe patients with severe mental disorders. And her question was, how do ambulatory, I find it a difficult word, mental health care professionals understand and practice spiritual care in their daily work? She first interviewed the mixed team of mental health care professionals and professionals for protected and assisted living. These are two different organizations, but they work together in community teams. And after that, she did observations in home visits where the professionals talk to patients. And in the second phase, she had two focus groups of the different organizations to validate the results and to talk with them about this slide Line talked about already, about the difference between a pragmatic and a contemplative attitude. So the focus on the interviews and observations was twofold. How do professionals understand and practice recovery-oriented care? It is because Utrecht as a whole, but especially when you work with severe mental disorders, the recovery-oriented care is being adopted more and more. And how do professionals understand and practice spiritual care? And which role does spiritual care play in the recovery-oriented care of the interviews? Recovery-oriented care is one of the long-term, how do you call that, strategic goals of Utrecht. Recovery-oriented care, what do people view? How do professionals view it? They lay an emphasis not only on clinical recovery, but really on personal and social recovery and restoration of personal and social roles. They find that helping patients with gaining control over their life is their most important task. And what is very important to be able to do so for patients is acceptance of their illness and losses that accompany their illness, and take vulnerability as a starting point to think about the future. What do? They have a patient, professionals have, when in the observations, have a patient-centered focus. They try to tune in on the needs of patients. In the treatment plan, it's not only about clinical and recovery of symptoms, but a lot of life domains are discussed in the contact with the patient. And they don't work always very goal-directed. They try to stay next to the patient and walk along with patients. The presence approach is a theoretical, I don't know if you have heard of it, people in the Netherlands and Belgium have. It's an approach of Andries Baart, with tries to train professionals in being available and receptive to the needs of patients, but also to be able to endure severe suffering, because a lot of patients are suffering long periods in their lives, and you cannot fix that always. So you have, as a professional, also to be able to endure this suffering of patients without yourself giving up hope for them. And they use also their own experience of vulnerability, because they say we are all human beings, and we can see patients suffer, but I also suffer sometimes in my life. As a professional, I have more knowledge, but I can also share that I'm a vulnerable human being. Spirituality and meaning making. Well, when Cis asked, what is zingeving? They said, oh, this is a very difficult concept. It's so complex, abstract, broad, we really don't know it, in fact. But they answered by questioning. It is about what is important in my life. What do I want to achieve? What makes me happy? For what am I on earth? So they asked questions in answering the question what zingeving is. And they recognized this double meaning of daily experiences of meaningfulness, which can be very small or large, but in daily life, and spirituality, belief, existential questions that need more reflection. Well, Line has elaborated on that enough. So what is their practice like? They have a great interest in, the professionals have a great interest. They were very much interested in the research, and that was the same in Line's case. They recognize that it's a very important topic, spirituality, for patients. They start with the questions and needs of patients themselves. And they have an attitude of engagement when patients come up with existential questions. But they have a timidity and reservation when it comes to religion. Then they refer to the hospital chaplain. So that can be a problem, because there is a very diverse patient population. And some say, well, it's in the treatment plan, it's a care domain, so we have to do something with it. What do they do, and what do they expect from the spiritual caregivers? They expect for patients that they help them to live with despair and severe suffering. Then sometimes they ask us to talk with a person when there are cases of grief, when there is a specific religious language, a religious or spiritual language, which is usually another language than the attitude of or the affiliation of the professional, him or herself. And when people ask for euthanasia, then often also they ask a hospital chaplain or spiritual caregiver to talk about that with the patients. But they find, when there is a spiritual caregiver in the team, they find that they have a different perspective on the request for help, and they can be a sparring partner, and they are asked when moral dilemmas pop up. Now, this is the dia of Line, and Cis talked about extensively in the focus group about these two ways of perceiving spirituality and the accompanying attitude. And in fact, results were the same. They said usually we work in a pragmatic way, but there are also people that have a contemplative attitude by themselves because they find spirituality important. It's not very different from what Line already found in her research, so I will skip this. What they concretely said about what they need is more tools for personal recovery and spirituality. The treatment plan is not tailored for recovery-oriented care because it starts with the description of the problem of the patients by the professional. And they say we need another way of describing problems which is more personal and where patients are more directly giving their input to. And then we could also do this for spiritual care. This is a broader problem than only spiritual care. It's for over recovery-oriented care. It's a problem. They said we need more personal tools and a care plan that is more personal too. We need availability availability of spiritual caregivers. And another thing, they said it's not only a question of time and money. We need more time, but it's also a question whether the institution has recovery-oriented care and spiritual care really as that they support it, but only also think it's important for the general treatment goals. If they don't do that, we can do nothing. So there's a funny difference between the two teams that the two kind of professionals that Cis interviewed. Because in the assisted living professionals, in the community carers, they have it more in the treatment plans. They talk more about it than the Utrecht professionals who are more medically oriented. And they said, well, we need spiritual caregivers, but they don't have it. Only Utrecht has it. So Utrecht, so to say, puts the problem in the lap of the spiritual caregivers instead of integrating it more in the treatment plans. Now, the conclusion of the two studies is that spiritual care is not integrated enough. Professionals really recognize the importance for patients, and some are more competent than others, but on the whole, professionals are more competent in a pragmatic attitude and spiritual care than a contemplative attitude. And they would like to have more time and support. So that's, yeah, I have to look at the time myself too, because I'm chair, but now we have time for some questions and answers. So I think you can sit here. Yeah. Really, yeah. Because I think it's good to have some time. Who has some questions or discussion points?
Yeah, just a question of clarification first. Could you explain again the pragmatic attitude and the other one? Just so, because you explained it well, but it went a little fast, so maybe you could flesh it out again.
Yeah, sure, right. The pragmatic attitude is more focusing on well-being, that you have some quality in life, you have some meaningful activities and purpose. It is about zingeving in de zin van er zin in hebben. That's hard to translate for people who are not Dutch. And it is also about spirituality in that you just understand yourself in life, and how do you say that correctly in English? Translating zingeving is super complex, as you already find. But it is more about that you have a kind of well-being in your life. And the other way, the complementive, is more about the things that are beyond everyday life. The existential topics were mentioned in the talk before lunch, for example. And the attitude is more about reflection and introspection, and less on helping in practical sense. Hopefully,
it seems of Yano, for example.
Yes.
Loneliness, death. Who am I in this world? Why do I suffer this?
Feelings of meaninglessness.
That would be the contemplative side.
Yes. Yeah.
Okay, that's helpful. Thank you.
And where did you get this from? These two, from the literature or from the response from the literature?
It's from an empirical study from the Rijk, Mutet and de Vecht. There are some colleagues from the north of the Netherlands, and they also did an empirical study in the same kind of group of professionals, and only observations, I think, no interviews, and they make this conceptual difference, and I go further
it's
with
a Dutch project.
Yeah, it's a Dutch project, and that's, we struggled a lot with the translation, because the way they split up the spiritual care approaches and they split up the understanding of spirituality is very Dutch orientated. It's hard to.
It's interesting, but I didn't hear of this.
But does it ring a bell? I mean, do you recognize it in healthcare?
Sure, but I would call it a little bit different. I think the second one is really the pastoral care approach, more the pastoral care approach, and then the first one is maybe more the professionals approach. Like the focus is not on pastoral care. The focus is not on make the person more whole or whatever. The focus is more on just to some kind of improve their health or improve their coping or improve their more functional. Yes.
Yeah, that resonates. Yeah.
Yes. I was just trying to make it practical, so someone maybe feels lonely. In a practical approach, you would maybe try to create some social activities around them so they feel connected practically, and they feel like waking up in the morning because I have a game to play and so on. And the other one is more that you reflect with them on what is this loneliness?
What does it mean?
What does it mean for your life? Or so it's more conceptual, perhaps, or
and more existential. Yeah, I think you give a great example. Yeah, it is exactly this point. Yeah.
The second
construction is more also in the field of the psychologists. I mean, yeah, I found it very clear, but I'm looking at Alfred and also Nederlander. So this sounds very logical, but I'm wondering, so it's not very international.
It's a good question. It is a good question. It was in the presentation, but I forgot to speak it out loud. In the group I interviewed and observed, the psychiatrists and the psychologists were absent. They just didn't show up with interviews because they didn't have time. So they are absent in this research. And what you said really resonated with me because I made a training based on this results, and I give it in a teams with different disciplines, and exactly the same came up. So for the professionals who are psychologists, they said like, oh yeah, for me it feels more natural, for me it feels super logic, and the other professionals, for them it was more like eye-opening. So I think it is a good nuance and a good correction that the results are more gelden meer voor. Applied more for like case managers or the nurses than the psychologists and the psychiatrists, because they are not they didn't attend in the research.
Okay.
I cannot see if there are any questions in the chat, but I don't think we have also time for it. So then I give the chair back to you.
Yeah.
I have one question though, maybe this is for everybody, but I'm not a clinician or a provider, but are there places in the electronic health records of any of your facilities where you can put in spiritual care? Is there a designated place for spiritual care and care plan dealing with it?
Yeah, Cis on research was more about this. Would you like to answer it?
Yeah, there is, but it's often not filled in. It's not systematically, there's no systematic attention for it. So that's what the professionals said. We need a care plan that is more tailored to an individual patient, and then you can follow a track what they need. But so there is some space, a patient has affiliation but it's not really filled in, and the spiritual caregivers don't write in it. It's not done in the Netherlands for mental health care. So this is really a way of developing, because after 10 years it will probably, hopefully, be a bit different and in a more systematic way. But now it's not.
Yeah. So in a digital treatment, it is very narrowly approached.
Yeah.
And the spiritual caregivers, the chaplains, they are not writing in the digital treatment. So there is, I think, a gap between what is written down and what is the lived experience.
Would you say, would you like to do that, to write in the digital reports like all the other disciplines? Because where I work, I think that all my chaplain colleagues are very hesitant about it because of the guidelines.
That's a very interesting discussion. I'm not sure if this is the place to do it, but I think for the not chaplain professionals, just for the nurses and the psychologists, it would be, I think, helpful when there is a space in the digital place to write down in it. And if the chaplain should write down on it, yes or no, is maybe discussion for later. Yeah.
So you are not very clear pro or con?
No, actually not. No.
I'm very clear.
No,
I'm very clear. You know, I think it's mandatory. If you really want to practice the spiritual care concept, it's mandatory that all the disciplines, including the chaplains, documents what they do.
But it's a difficult thing, because in out of the patient organizations had advised the management not to allow us to do it, because they have a strong advisory mandatory to the Raad van Bestuur, to the management. So we are in a constant discussion about it. I agree with you, but it's not
There's
that
no
far.
logic, there's no logic. If you write that down, everything about biography, about sexual life, about whatever. I mean.
Yeah,
what
but
is the
then
difference?
patients don't like either.
What is the difference?
Yeah.
It's just new,
Yeah, and it has also something to do with this.
I think we have to
Vrijglaas.
stop.
Yeah.
Because otherwise we have no time for the e-help module and for Guus's presentation too.